invite our panelists to come to the table. And Karen, how much time do we have for Q&A? Till 5. Okay, so that's about 15 minutes, folks. So I want to definitely encourage and open up, and I see folks are lined up. So that's excellent. So I didn't have to actually prompt you too much. I just want to, let's give a big thank you to our panelists because they provide a lot of really rich information. So I definitely want to thank Dale, Samantha, Sharita, and Dennis, and I'll turn it over to this gentleman for the first question.
Thank you. Yeah, my name is Bob McClellan. I'm from Dartmouth-Hitchcock in New Hampshire, and also Geisel School of Medicine at Dartmouth. And also relevant to this question, I practice occupational environmental medicine. So I just wanted to make a brief comment that something I really haven't heard about, and that is occupational health, employee health. Politico and NPR ran a great series last year, I believe it was, on the erosion of workers' compensation throughout the nation and the impact of that in terms of the care of work-related injuries and illnesses, which, by the way, not surprisingly, inequitably is distributed across the nation. So I just would want us not to forget the fact that people are made sick by their work, and obviously undocumented immigrants are particularly and well known to be concerned about reporting work-related injuries and illnesses, let alone getting care. It's a very significant issue that I think needs to be raised to a higher level.
Anyone would like to make a comment? Thank you for raising that issue. I'm going to turn it to Dolores.
Okay, thank you. Thank you, panelists. I guess mine is a question related to what else can we do in terms of upstream strategies. You know, a lot of comments have been related to, you know, increasing Medicaid, more resources, more funding, which of course we all want. Dale, I think you made a comment specifically about that, you know, in 20 years, if more was invested in education, then we'd need less than that. But I think that, you know, so that's what I'm asking is what can we do in terms of upstream strategies?
Who would like to take that one?
Okay. We need to look closer at our models of healthcare facilities. I believe I mentioned in my presentation that I have visited 51 of the 54 rural counties, everything healthcare related in those counties. Not one time did I see physicians, clinics, and dentists sharing the same space and taking advantage of the economies of scale, at least with the same waiting room. We need to look at the models of facilities that we have to take advantage of the economies of scale and to bring other things that are sorely needed, like mental health care, into the mainstream. So that is one thing that we need to do right now to see the benefits in the future. Needless to say, we are going to have to start reimbursing better and concentrating on prevention. Prevention.
I'd like to know exactly what do you mean by upstream in this context?
I mean those strategies that look at root causes, that change the outcome so that what you're looking at is what can we do upfront to prevent some of the downstream activities. So for example, with grandparents raising grandchildren, we're doing a study on what can we do to stem the tide, right? Rather than just increase the number and percentage of grandparents raising grandchildren. So an upstream strategy is if we decreased teen pregnancy, then there'd be a direct correlation in terms of the percentage of grandparents raising those young babies.
I definitely don't have an answer, but what I'd like to say, and just talking from the U.S.-Mexico border region, where people are actively resisting policies, but it is extremely challenging in the climate that has been developed, the climate of fear through anti-immigrant laws, and practices for communities to organize. And I think about what I was speaking about in terms of the community health worker and the power of community health workers to bring marginalized, and I would say often terrified communities into the fold in ways that are safe, to be able to address the root causes that I think you're bringing up and that are so important in terms of affecting outcomes. But I will say from the perspective now, and this has been going on since around 2004, a lot of communities right now in the region are in a holding pattern, and they are definitely downstream. I mean, we're talking about really just basic planning around what will I do with my kids if I'm picked up, who's going to take over my mortgage payment, who's going to take over my car payment. I mean, real basic survival strategies with not a lot of time to be able to do the more long-term work. That's not to say that it's not going on, and I think in your state it actually is going on through the ACLU and different types of environments. But that's not from a healthcare perspective, but more of a structural determinants of health perspective.
I do think it's difficult to respond to that as if you're in an immigrant community in a climate of fear. I agree. But there are, I think, ways that at least in terms of children, that we can move the needle relative to their monitoring and addressing their healthcare needs if we work through some of the institutions where we find kids, like school, preschool, school, daycare, Head Start, those types of institutions offer an opportunity to, we've taken on an initiative called Healthy and Ready to Learn. And we screen for a set of what we refer to as HBLs, health barriers to learning, which are preventable illnesses that impede learning. And we think that this, if you're going to try an approach that's front end, what better approach is there than to involve caring adults in a school setting? And we find that parents gravitate to this model because it does empower them as well, and it recognizes the primacy of their role in their children's lives. To screen for these conditions, make sure that they're addressed, identified and addressed quickly. And we're talking vision, hearing, behavioral health, asthma, stuff of that nature. It mirrors a lot of what the EP SDT screenings do as well. I think if we focus on the front end of children's lives and make sure they're optimally healthy and learning appropriately and not missing school, that we take very significant steps forward in terms of improving the likelihood that they'll be healthy and well educated later in life.
Next question.
Could I say one other thing real quick?
Jill's got a
I'd like to
comment.
take this opportunity to make a point that I didn't get to make. We seem to feel that the people at the top are the ones with all of the brains, or at least that's the way we seem to handle everything.
No.
That's not true.
No.
We need to develop means for the people in the trenches to share ideas on how to improve things with those who are higher up. One example there, I recently emailed both senators from West Virginia and Alabama. Alabama is the #2 coal exporting state in the Union. President Trump made it clear that he wanted to help the coal miners who had lost their their ability to earn a living, perhaps with the only thing that they knew how to do. One thing I would like to see there, as dumb as I am, is federal dollars invested in grants to try to find more uses for coal, kind of similar to what George Washington Carver did with the peanut. He found over 200 ways to use the peanut. What if there are some other uses for coal out there that can revitalize that industry by finding new uses and perhaps cleaner uses for it?
Hi, I'm Sean Kennedy. I'm an ORISE fellow placed at CDC. And given that in telemedicine, one of the larger barriers once you can actually have broadband out there is just learning how to use the technology, have there been efforts to basically have children, not necessarily little children, but 8-year-olds and older, act as conduits for assisting their parents, their grandparents, other elders in the community with telehealth? And I guess that could be even applied to mobile banking and all those other kinds of things. I was just wondering if that was on the plate.
Well, there are some interesting telehealth programs out there. One I'd like to give a shout out to is the Center for Rural Health Innovation in North Carolina. A very forward-thinking pediatrician, Dr. Steve North, is doing some terrific stuff and really kind of blazing a trail in terms of technology and how it can be used to improve the connectedness that needs to occur through telehealth. It's a complicated situation because on the one hand you have Medicare, which is receiving a lot of attention on the telehealth side, but the flow of funding through Medicare is much more robust. Medicaid, being a federal state partnership program, some of the more interesting things are happening at the state level. So if you're, I don't know the answer to the question, but if you go to, there's an organization called the Center for Connected Health Policy, and they track this very closely, all of the developments at both the state and federal level, and you can get more information. I don't know of a specific program where young people are helping their parents or folks who may not be able to, may not be completely literate in terms of technology, but it wouldn't surprise me.
Ms. Romo?
Mr. Queenie, this is for you. When I heard you talking about the differences in the folks that had prostate cancer, the big differences, I just wanted to share with you that, and you said something else just a minute ago about, those of us that are not like you guys, because I think I'm different. Yes, we do have a lot of ideas. And in our community, when one of our people died of cancer, of prostate cancer, and I got in on it too late to try to navigate, but when he died, it made such an impact on us that we said no more. And so as a community, we went and learned about prostate cancer, and we started sharing it with the other, even though, they're men, we're women, but we're out there and we're gray-headed, so it's okay. And 2 men are now alive because we were able to share. And I think education is one piece that is missing. There's so much education that could be done, but people don't really give money for that. American Cancer Society, they have a lot of money, but they don't give it to you to do outreach. They don't give it to you to teach. So in the community, what I think all of us can do is, and the clinics, and I think they got to get a little bit, they got to loosen up and know that there's people in the community that make good teachers that can take the information about breast cancer, cervical cancer, every kind of cancer, and teach it and share it so that we save lives. And I think sometimes we're not using that to the full extent that we could, because there's this echelon of separateness of I know, you don't know. We can learn we can be good parrots, we can be good parakeets, and we can talk. All we need is the information and give it out.
You are absolutely correct. Our governor in 2015 established the Alabama Healthcare Improvement Task Force and named 39 people to that task force, and I was pleased with who he named. They were not the executive directors of associations. They were people out in the trenches. But the first thing that I did was to send out an anonymous online solicitation to all of the members of the Rural Health Association, inviting them to anonymously make suggestions and promising them that we would get those suggestions to all 39 members of that task force. We had some outstanding and highly controversial suggestions. There's plenty of intelligence out in the trenches. Call on it, use it.
Winston?
Thank you. Winston Wong from the Roundtable on Health Equity. So I asked this question fully realizing that most studies suggest that health care represents only 10% of the equation with regards to the overall health of populations and individuals. However, that 10% in the United States consumes 18 cents of every dollar we spend in this country. And through the last decade or so, we've been spending a lot of time in terms of figuring out how that 17 or 18% of every US dollar can be used more effectively. The government and my colleague here at CMS have been configuring all these different opportunities, accountable care organizations, alternative payment methodology, bundled payment. I come from a prepaid health plan. Do any of these things matter relative to whether they could make a difference in terms of what you have seen with regards to the deterioration of healthcare access and healthcare generally in rural communities?
So who wants to handle that one?
Wow, that's a tough one.
I think I would say that it does make a difference, because if you have some of these, like rural hospitals, for example, or rural health facilities, and they're constrained by some of these policies that weren't meant to fit rural areas, you kind of do have to think about alternative methods of delivery, and some of that comes down to how these facilities are reimbursed and what they're allowed to do. And there is Senator Grassley has the REACH Act that's out there that's looking at the different models of health delivery in rural areas, different ways to reimburse those facilities so that they can have the freedom to innovate and design a program that works specifically for their community, because it's not going to be the same for every rural community.
I would concur with that, and I think one thing you didn't mention was that the disproportionate amount of the expense comes as a result of a group that they're referring to as the super utilizers, the people who account for I think the numbers are 5% of the patients account for nearly half of the healthcare expenditure. And so I think it's absolutely critical that we continue to innovate and try and figure out how best to target the creative ways of managing the healthcare access delivery to that population, all the while maintaining our focus on the broader public health questions and commitments that we need to have to ensure that the public's health continues to improve as well.
Sorry to have to cut off. We're at 5 minutes past the hour, folks, and I feel for you, but you can grab the panelists afterwards. Let's thank our panel one more time, please. And I'm turning the lectern over to now George Isham.